And this came from a clinic in Shasta where they sort of actually had an exercise where they gave everybody jelly beans and they said they went through the different jobs that need to be done in primary care and put jelly beans in the cup. The people who do them now. And the provider's cup runneth over. You know, there's a lot of stuff that doctors do and nurse practitioners and PAs do that they don't need, you don't need that level of licensing to do that. If you redesign care, put the jelly beans, everybody gets some jelly beans and the patients are happier and care is better. And the providers get to go home on time at night and enjoy their jobs and stick around. And I've read that it costs $300,000 to replace a primary care provider. You know, to recruit them and train them and get their patient base going. And I see you're nodding. More now. Yes, yes, yes.
Yeah. He's saying it's more than $300,000
more than
to replace.
Yeah. And so it's more than salary that makes doctors want to stick around and be happy. And you know, we've set that up. It was a great pleasure. I mean, I disrupted my life in Humboldt where I got a job I liked in a practice of 30 years of people were saying that. Actually, I closed my practice about 6 months after we opened it. Had one family with 5 generations. You know, it was a big deal to go to Stanford, but it was to set up, start from scratch, and set up a clinic that I really felt like, with my husband, that really felt like this is the team care that we wanted to do, and this is what patients needed. So it was quite an opportunity. That we really feel that it's important to identify providers' panels, and actually our medical assistants have panels. And that's a kind of a radical idea, but it's really been a cornerstone of accountability in care. And so the patients interact with the same medical assistant, and we actually promoted them and call them care coordinators. Now Stanford is about to adopt a 4-tiered salary level for medical assistant to care coordinator, so it allows some career advancement in that track. And every staff member works to the limit of their credential. I can't say licensing because medical assistants aren't credentialed. And by the way, we have a Stanford Coordinated Care website, and all the protocols that we use for the pharmacist and the medical assistants are all there, and feel free to use them. We like to be attributed to us, but it doesn't cost you anything, and we haven't copyrighted them. We want them to be used. It's really important that the team feel a sense of mission, and we spend a lot of time with our team, and we get a new team member, a lot of time telling them about the history of what we're doing and what we're trying to do, and how it's patient-centered, and having them talk to patients, and our patient advisors will meet with new providers. We even have our patient advisors help selection of our staff, and all the medical assistants participate in the selection of new staff. So that really enhances the team part. We have to have clinical systems and administrative systems to make things easy and to get rid of the gumption traps. Patient has to be seamless to the patient. And that's one nice thing about our care coordinators having their own panel of patients. They're in the room, they do the assessments of the patient, they scribe the visits, so I don't have to look at the computer, I can look at the patient. And they order we have protocols, they do all the ordering refills, routine medications, they do all the HEDIS measures of routine care. Yeah.
So let me understand that. So while you're talking to the patient, your medical assistant is doing the scribe work.
Right.
So it's not disrupting the patient relationship.
Right. And not only that, is that the medical assistant learns about what's going on with the patient, learns about what's important to me, what's important to the patient, and can deal with a lot of the, we set goals and action plan with the patient, and it's not a handoff to, oh, this person, one patient, her action plan was eat broccoli on Saturday night. I'm not kidding, that was her action plan. And the medical assistant care coordinator called her up on Monday and said, how was the broccoli? And it was good. And actually now she eats 5 a day, but if I had said eat 5 a day, it never would have happened. But because the medical assistant care coordinator was in the room scribing, she knew that was what was going on. And also about 50% of the emails and phone calls that come to me are handled directly by the medical assistant care coordinator because they know what, a lot of them are routine things anyway, but they know what the patient needs. Yeah.
What's the panel size for the MA?
MA have 100 patients. I think in a primary care setting, it could be more like 250 or even 500. I don't know, you know, but that's, we got over 100 for a while, and then they started being cranky and working overtime, and you know, and then so we hired another. We have workflows clearly defined and assigned roles, but support for people when things, because patients don't necessarily follow neat tracks. So we have communication, and as I said, one of our communication, we meet a lot, and we sit in the same room. And so we talk, there are a lot of health systems that are working towards a scribe thing, and we call that the production line or assembly line model. And that means then you have to hand it, you know, it's a loss of training time for a medical assistant or care coordinator who could be there learning about the patient, learning about the conditions. And that's actually how a lot of the training is. Have a new care coordinator pair with a nurse or medical assistant to do the, you know, sit in the room and learn about that. And from a patient's point of view, it's one person that they're interacting with. And from the medical assistant's point of view, it's a lot more fun. They say it's more work, but they like it. You know, they are responsible for the case presentations at team meetings, so every new patient is presented by the care coordinator, so it's a check on that they know that what's important and what's important to the patient. You know, as I was in the room too, I get to see how they view things, and it eliminates handoffs. So, and I think the big plus is not just piling it on medical assistants and engaging them in the process of developing this new job category and paying them for the work that they do. If things done to people, they don't like it. If they're done with people, they're already there. We use Epic, and we've done some customization of it, but one of the things we put have this for every patient, so their PAM levels right up here. When you open the chart, you see it, and here's the patient's goals. So Clark Kent's goals, and he's one of my patients, is to become weightless, avoid Krypton, and get married to Lois when he's healthy. And his action plan is to fly 3 times a day, you know, a very specific thing, and he had some shoulder pain, so he has to try a lighter cape. And, you know, so he was going to see our physical therapist and get his screening test done. So but every patient has their goals, and it's actually the care coordinator's role at every visit to update the goals and the action plan and check on that. And if we had better tracking system, I think I admit we're not great on that, they would do a better job between visits at tracking the action plan. But we've done some work with both graduate students in the design school at Stanford and now medical students to help with the action plan follow-up. Here are results on the HEDIS measures, and you see we do better on the ones that are just the performance measures, you know, of getting the colon cancer screening and getting the blood pressure measured and getting the A1C test done, getting the nephropathy screen done. We're all in green for those, and some of the ones that are doctor work, where it's actually controlling the blood pressure or controlling the A1C, you know, we have to work with the patients on that, are harder, we're not in the 90th percentile, so care coordinators are doing well there. But we post this, you know, we have visibility boards, so our patients can see it and our providers see it. We have one of our care coordinators, Delilah Coleman. You see, they work with different doctors. It's not a one-on-one teamlet like the Tom Bodenheimer model, because we feel the important link is with the patient, and you know, it gives more flexibility to have the medical assistants be able to team with the different doctors.
Could you elaborate on that? I didn't understand what you were saying with the contrast with the Bodenheimer model.
Yeah, well, Bodenheimer, and I give him tons of credit. He's wonderful and he's done a lot for team care things. But his model is a teamlet where there's a provider, a licensed provider, and a medical assistant who work together. And that, first of all, I think it takes about 3 medical assistants to support That's the ratio, and our clinic is 3 to 1. And there are a lot, you can hire 3 medical assistants for the cost of 1 nurse in California, by the way. You know, so our nurse supervises a bunch of them, and you know, it would be beneath her licensure to do a lot of what they do too. So, which is basically be a peer and a partner. But the Bodenheimer is a teamlet, and that's important because a lot of clinics run with 1 medical assistant. Well, one of our medical assistants, Delilah, in fact, serviced 7 doctors in the clinic before she came to work for us. You know, so it was a different shift. You know, when they room patients, and that was it. We hired people who were. We asked the clinic manager, said, "Who's getting in trouble for doing too much?" So send them our way. And it's part of our interview process.
And Ann, how many total clinicians in the SEC currently?
We have 3 doctors, but there's like 1.6 FTE. And we think the doctor panel is between 300 and 350 patients. There are other models, like Intermountain has 75 patients for every doctor, and I think we're about to meet with them. And I don't think they're probably having the doctors do the requisitions and things like that. But, and then the top is 500 that I've seen. But anyway, this is how Delilah, it pulls from Epic. This is a care gaps tool, so things that she's empowered to do by protocol without me having to, think it up and sign an order at first. She can pull up and see who needs what. So flu shots, for example, you can see who's red. Okay, those are those. And it's patient. You can't all the patient names that got taken off this, but it's really important to have your data, your gaps tool, be patient-centered, because if you have, Epic has a diabetes registry and a hypertension registry, and you have to go in 5 registries to see. I mean, you interact with a patient about one thing and you miss the boat on all the other ones. So it's really important for your data, chart records to be patient-centered, so you can see what one patient needs. And we've set up metrics for 10 chronic conditions, but Stanford stopped building it out about 4. So we don't do as well on the other chronic conditions that aren't built out. We have a risk dashboard. So one of the things we do, because I work with 4 different care coordinators, is we have once a month we have what we call speed dating, where we sit down and the doctors rotate around to the care coordinators and we talk about our mutual patients. We have a dashboard that identifies people as red, yellow, or green for a number of conditions. And we talk about who's red and what's going on with them and what do you know about them and who else needs to interact with them and how we're going to fix it. And I'll tell you the hardest one is people whose body mass index above 35 are red, and it's really hard to move them off. But they're still red, and not that we can fix it all the time. And some of it is history of smoking, for example. And our patient activation measure, if you have a 1, you're red. So, but it's a way of us, we want to get the red out. It's a way of focusing care between visits. So we're really working with the people who really need the care, as opposed to people who show up on our schedule. And I've been a doctor long enough to know I did that for years. Wherever somebody show up, I deal with it. And in between time, I didn't really have a method, or unless I remembered or I ran into the grocery store and didn't remember. And so this is the speed dating process. So we pull out of that risk dashboard just to get the reds. And we address the care gaps at those too. And from time to time, we have specific care gaps that we're focusing on, like colon screening. Now it's making sure, it shows up if you haven't had a visit in 6 months or any kind of interaction. So let me tell you about, what does this mean for patient care? This is a patient who came to see my husband, Alan Glassroff, and we had claims data for him for 6 months prior to enrollment. And he worked at the hospital as a medical assistant. He was on dialysis, and at one point he had peritoneal dialysis, another time hemodialysis, and he needed a kidney transplant at some point, but you know how long you wait on those lists. He would go, he actually, and get dialysis at night so he could continue to work on his job. And I can't tell you how many of my patients are heroes. I mean, for the things that they live with, and the things they carry on, and, you know, they just carry on with their lives. They really are, they are the heroes in this. And, but he had in the 6 months, he had 4 urgent inpatient admissions, you know, for syncope, sepsis, peritonitis, and osteomyelitis. And he had 1 PCP and 5 specialists, and with a $627,000 bill charges in 6 months. And he was on immune suppression for his eyes, and immune suppression for lupus, I think he had, and from 2 different specialists, and he was so suppressed that he gets infected all the time. And he had a corn on his foot, and none of his specialists were podiatrists, and the primary care doctor didn't actually see him all that much and really couldn't help him deal with corn. So Alan paired his corn and you know, and made sure his feet were getting care of so he wouldn't get osteomyelitis. And had a conference call with all of the 5 the relevant specialists and said, you know, you're all doing a really important work of protecting his eyes and his kidneys and things, but you're killing him. And you know, can't you back off a little bit and coordinate the immune suppression? And they were able to do that. And they had a family conference because this guy was, you know, because he was so tired and so busy and in the hospital all the time, was actually missing the most important visits with the renal transplant clinic. And they were about to, you know, chop him off the list from a transplant. And so they really had a family conference about, wow, that, you know, in prioritizing your visit, that's a really important one. And they developed an action plan with the patient, which part of it was follow through with the renal clinic. And the care coordinator basically was on the phone with him and touching base with him several times a week. It really felt like we had his back. And so, you know, on the lower left was all the conditions that he had. You know, so it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, he had a little more than the average patient, but that's kind of less patient. So that's why it takes like 2 hours initial visits. So after enrolling in the subsequent 6 months, his bill charges were $7,837. And he was not admitted at all. And he cut down on some of his specialists who were less, you know, taking up his time but really not contributing to his well-being. And basically started really doing much better. And so considerable cost saving, patient was satisfied, and the outcomes were improved. So it's a little bit about how, you know, our team interacted with him and how we interacted with the other people outside of our clinic to make sure his health care was coordinated. Yes?
Do you recall if there was a conversation with this particular patient when he was admitted, and the question, you know, what's your goal? That fundamental question that you asked earlier?
Oh, when he was admitted to our clinic?
Yeah.
Yeah, you know, his goal was to keep working and stay out of the hospital. Yeah, I'm opening up for questions now, so that's good. But yeah, I don't have the screenshot of his, but that was something like he just really wanted to keep working. He was a very dedicated medical assistant. So.
Dr. Erdl here from Mercy has a question.
I know this is a younger population, but and who does the palliative care end of life discussion function and planning post-form and those kind of things on these patients? Because again, providing fetal care at the end of life to patients that don't want it is a dumb thing in general.
We've had 5 patients die, and they're all my patients. I made home visits and did all that stuff with them, and they all but one died at home. Because that's what we do. We've done a lot of, we have some staff training that we're going to do. So right now it's the doctor who brings it up. Our nurse and our social worker also have worked with people around advanced directives. The post is obviously a physician thing. We found really helpful is these cards called Go Wish. I don't know if there's a Go Wish website. There's cards that, because a lot of people don't know how to talk about the end of life because they don't know what the options are. And it's a series of cards, and maybe there's like 30 of them. And you go through them with the patient. And I had a patient who had metastatic pancreatic cancer, had disastrous swivel, and they said nothing else is going to help you. And she wouldn't talk about advanced directive stuff. So I got these cards out, and some of it's like, what's important to you? And so the patient puts the cards in 3 piles. This is what I really care about, this is what I sort of care about, and this is what I don't care about at all. So I learned from her what really was important. And she wanted to be not in the hospital anymore. She didn't want pain. She didn't care really about spiritual stuff. It's not me. That and she didn't have a lot of money, so having her financial affairs in order wasn't all that important. Those are the kind of questions. So I was able to get her to open up and make some real planning about it. But prior to that, I'd been meeting with her a long time and never got anywhere. So I think that that's a very, and we have, there is a SIMS, the Simulation Center at Stanford, and we're putting our whole staff through that about talking about advanced directives.
What's this deck of cards called?
Go Wish.
Go?
Like
Go
go
fish.
fish,
Like-
but go.
Yeah, like Go Fish. The website's hysterical. It has these women look like they're playing bridge, and they got the Go Wish cards. But it's, you can buy the cards, you can play it online for free, and it's a great conversation starter that anybody at any level of
Great.
training. And then we put that in their problem list. So anybody who interacts with them actually looks at the problem list, sees what's important to them. Yeah.
You talked a little bit about Bodenheimer's model, and in some of his stuff he has the MA also acting as the health coach, and you're using the word care coordinator, so I'm just trying to envision, you said there's sort of 4 levels of the MA's progress. Is part of that learning how to be a health coach? Is
Yes.
part of it learning motivational interviewing? Or so
So the 4 levels of MA, and obviously the basic level is putting the patient in the room and taking the vital signs and getting them in, right? Which is, some people prefer to stay at that level, and that's what they're doing. But, and yes, our care coordinator very much are health coaches. They all get motivational interviewing training, and which we provide. I mean, we actually have a team training center we provide to other teams who come. And they learn it on the job, of things, and we kind of keep each other in check of like, you kind of told that person what to do. You shouldn't have asked them what they were willing to do. Health coaching is one of it, and just a care navigation is another function, scribing, and just logistics support. So those are the main categories which our care coordinators do. So yes, Bodenheimer describes it all. I just think you need more of them. And really, I think the advance that we've done there, I feel that Bodenheimer says is important too, is the empanelment on the MA level. That they have their patients they're responsible for. It enhances their satisfaction with the job. It enhances their ability to give personalized care. It enhances the patient's relationship to the team. And it's one thing we got pushback from our patient advisors. They said, we don't want medical assistants, we want nurses. This is Stanford, you gotta have nurses, because they learned at all the other clinics. The only people who know anything going on and that are there all the time are the nurses. We had to say, trust us on this one. We'll make sure that people, and we introduce them as the key members of the team during our first visit and say, they're here all the time. I'm not. They know how to answer most of your questions and find me when they can. And so the patients wanted to trust them.
I don't want to dominate, but did they get a financial, like you talked about them being able to have higher, is that tied to certification as a coach, doing a training?
That's in development. They get 10% more than medical assistants, which is not whatever. But Stanford is redesigning their primary care, and I don't know when that's actually going to happen, but it's incorporating a lot of these elements, and they're going to have a 4-tier level, which require certain skills, assessment, and tied to higher pay. Yeah.
I was intrigued by one of the early slides that you showed that had, I think it was 3 words. The first was human, I think the next word was centered, probably the third word was care. What I'm wondering is the difference between human-centered versus patient-centered, and how that has played out in how you have imparted and infused your values into the organization and what you all do.
Good question. We actually have now worked with some of IDEO, the design firm in Palo Alto, that they actually develop the mouse and things like that. They do human-centered design. And it's in context like for shopping carts or computers or, you know, airplane seats or things like that. And for us, the humans that we interact with we're clearly identified as patients. And, you know, and they don't take offense that we want to say patient-centered design, but the context is as patients. But the point of the matter is looking at things from the consumer's experience and from their perspective and making things, you know, as seamless as possible and as supportive as possible and filling their needs in a comfortable way. Did that answer your question?
Yeah, it's a bit subtle, but a great deal of what you said reflected what I think is probably the difference between human-centered versus patient-centered. The human-centered is the larger construct, and it seems as though you're dealing with your, quote, patients as in a much larger context than is normal in most medical care settings.
Right, and that goes back to our assessment of the 4 domains. And, you know, if the most important thing for them is that they get to walk their dog, or you know, we know the dog's name, we know their kid's name, where they live, and this kind of thing in primary care you learn over years. And that, so in the sense that we don't limit people, the context we interact with people to their patienthood, it's to their personhood. So that's a good point, I think. It's part of being a good primary care person or any kind of doctor or provider.
I suspect that some of that learning for you and your husband, or anybody, could have occurred only in a rural context, perhaps.
Well, I think people, and I mean that helps because you run into people all over the place in a rural context, you know. But really, anybody, that's one of the things that you don't learn in medical school and residency. That one of the joys of primary care is the long-term relationships that you have, whether you work in an urban clinic or in a rural setting, whether you work in private practice, or, you know, whatever. It's that being that way with patients, right? Yes, Jessica.
You mentioned shared savings agreements.
Right.
So where do the savings, when accrued, how does that play out in this model?
I'm not sure we're ever going to get around to that, but there are groups that do that, and basically you predict what the cost, have an agreement about how you predict what the cost would be for your cohort of patients, and look at what they actually cost. And then the health plan gets some, and the provider gets some. And it's a commonly talked about term. I'm not sure whether it's commonly
Defined?
actually carried out successfully.
Well, you know, the Medicare MSSP program, which is built on that model. It's built on exactly that model.
Yeah, I guess in the conversation of finding funding to do prevention, a lot of people look to these, but then the question is, you know, some sort of more conservative groups feel that all savings should go back to the patient and lower premiums. Some people believe it should go to providers as performance incentives. Others believe it should go even away from the health system to the community in accountable communities for health, like, you know, building safer environments for everybody, not just the enrollees. I'm just trying to get a sense in a model like this that's actually benefiting, and I would assume creating savings. But it sounds like from your description, it's just staying within the system to the health plan and providers, and not going outside of that or back to any investment in technology.
Well, I'll tell you one of the things that we do with it. I mean, since my salary is my salary anyway, I'm not going to get more money out of Stanford. It would be buy more, give more people access to chronic disease self-management, tailored chronic disease self-management program, for example.
That's a great
There's a tuition
use
involved.
of it. Yeah, yeah.
And we've used funds that we've gotten to pay for that for our patients. And then we're actually contracting with the university to do the disease management piece that they often will have telephone, you know, the health plan does telephone management. And so give us that, and we'll do in-person and online chronic disease self-management you know, for same amount or less money, and we think it'll have more of an impact. So,
Thank you.
yeah, it's something that needs to be negotiated, but I do think one of the lessons from Pacific Business Group on Health is it helps to incentivize the providers. And it helps to incentivize the health plans so they continue to support the providers. You know, they need it, yeah.
You sort of mentioned early on that there's a source of primary care physicians, and you have panels for your MAs, which I think is a great idea. You need 3 or 4 of those for a primary care doc. You sort of imply that the panel size you're looking at for your primary care docs are about 400 or 500. How is that generalizable as a solution given the shortage of primary care docs?
That's an excellent question. You know, we have very complex patients, and so it's not a model for primary care, but we work with the Bellum Health System in Wisconsin, and they came and, you know, brought providers, and actually the doctors were the hardest ones to convince to share the care. And but they went back and adopted the model, and you know, they went from their provider, I forget what it went from, like 1,500 to 2,800 that the primary care provider could do with all this assistance. You know, and Christine Simsky writes about the joy of practice, and talks about how in her private practice environment that increased productivity. You know, so that and maybe in a primary care setting, people don't need as much support as ours. They don't need a once a week contact. You know, so they can have 500 patients or 800 patients. You know, depends on how you have to. Yeah. Okay.
There was a question back there, I'm sorry. Yes.
Oh,
Did you have a question?
I'm very excited because I'm not a part of all this. I really have a human development background. And so everything you're saying makes total sense to me. The relationship and the enhancement of the model so that the employees as well as the professionals have a quality of life that gets them, sustains the work. See, the sustainability of the work is critical because if everybody's not bought it, I learned that when my mother quit working for medical center. When she quit, she was just an LVN. But the whole floor quit, the whole floor. Everybody moved out when she left.
Yeah.
So after 20-something years working on that floor, they didn't have somebody making them feel like they were part of a community. When she left, then everybody moved from different floors. That whole floor had to be staffed. So I like what you're saying. It makes a lot of sense to me. And although I'm not in a medical career, the developmental process of human beings has to be considered in the model. And so I'm very excited about, actually, I saw your name and I wanted us to get here because I was like, I'm on this. So thank you so much. I really enjoyed this. I really want to say I really enjoyed the presentation, and the application could happen in anything. It really doesn't matter that it's in a medical field. I could see it being in parent involvement, anything. It has to be, this model makes sense. So thanks.
Well, thank you. We say we practice extreme team care. You know, and I really did as a provider. I always had trust in other professionals, in other team members, but it really it takes us some practice. But the other, you know, we say football teams practice 40 hours a week to play, you know, 2-hour game. And we practice, medical teams practice almost nothing. You know, but from an HR standpoint, one of the metrics that we're following is the SPS 6, which is a presenteeism scale. And we can't see the, you know, at Boeing they looked at absenteeism, but at Stanford that the absent days or sick days are mixed in with